Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. I have been a cardiologist at the Texas Medical Center for more than 3 decades. And today we are going to talk about congenital heart diseases. So let us begin. You may not come across every congenital heart disease in your practice, but nonetheless it is important to know when and where to look for congenital diseases when you are screening patients for heart problems. There are a variety of congenital heart diseases we may encounter in the adult population, and we are going to cover the most commonly seen congenital heart diseases. First, let us talk about atrial septal defect, or ASD as it is called. Atrial septal defect is one of the most commonly seen congenital abnormalities in the adult population. It generally becomes apparent in the 3rd and 4th decades. In majority of cases, the atrial septal defect could be asymptomatic. There are a varieties of atrial septal defects depending on the location of the defect between the right and the left atrium. The secundum type of atrial septal defect occurs where the fossa ovalis is supposed to be, and this accounts for 75% of the atrial septal defects that we see in the adult population. The less common ones are the primum atrial septal defect, which is at the lower end of the interatrial septum, and the least common of which is the sinus venosus type of atrial septal defects, which occur at the junction of the superior vena cava and the inferior vena cava. An important thing that we need to keep in mind is that sometimes atrial septal defect may be a result of maternal rubella. It is also commonly seen in patients with the Down's syndrome. So if they are describing a patient with the Down's features in a question, then you may be looking at either atrial septal defect or ventricular septal defect. That is why all these side attractions are very important as far as passing the boards are concerned, because those are the ones which are going to get you some points. Patients may present with shortness of breath, edema, fatigue. Occasionally, they can present with a stroke with a blood clot coming from the right side of the heart, going across the atrial septal defect and lodging in one of the intracranial branches. In atrial septal defect, the shunt is generally from the left side to the right side, that is from the left atrium to the right atrium. Increased shunts with a QP/QS ratio of greater than 1:1.5. There is enlargement of the left atrium, there is enlargement of the right atrium and the right ventricle. In extreme cases, the atrial septal defect can lead to pulmonary hypertension and Ising-Menger's syndrome, which we are going to talk about later on in this presentation. Generally speaking, atrial septal defect is asymptomatic, and we may find out some right ventricular hypertrophy on the electrocardiogram, but when the QP/QS ratio gets to be greater than 1:1.5, then it becomes significant. In most patients, we can diagnose this by a 2-dimensional echocardiography along with the transesophageal echocardiography. In recent days, we can close this atrial septal defect with a closure device, so we can avoid doing open heart surgery for these patients. These devices are pretty successful in closing secundum type of atrial septal defects, thus avoiding an unnecessary surgery. Let us talk about the patent foramen ovale, PFO as it is called. In the intrauterine life, there is an opening between the right atrium and the left atrium, and it is called the foramen ovale. It is like a flap actually. It is through this foramen ovale where the blood coming from the lower part of the body is preferentially pumped to the left atrium, then into the left ventricle, and then it goes into the aorta, supplying the oxygenated blood to the rest of the body. Right after the birth, this foramen ovale closes, but occasionally in some patients it may remain open. This patent foramen ovale may become apparent only as an unexplained stroke in a patient, and when the patient goes for an echocardiogram, then you find out an incidental presence of patent foramen ovale. In most cases, these patients are generally treated with anticoagulants. Rarely do we need to intervene surgically. Next, we are going to move on to bicuspid aortic valve. Bicuspid aortic valve is a fairly common congenital abnormality that we encounter in the adult population. Majority of these patients are picked up on a routine echocardiographic examination, where the echocardiogram, instead of showing the 3 cusps, may display only 2 aortic cusps, and we can clearly see their movement along with the 2 leaflets. Sometimes the 2 leaflets can join together to become one. As a result, we may see some indentation on the aortic leaflets. Another important thing that you should keep in mind is that bicuspid aortic valve means you need to think about Turner syndrome. All these associations are very, very important because they are all exam questions. Similarly, when you think about bicuspid aortic valve, we should also be thinking about Marfan's or coarctation of aorta. Bicuspid aortic valve, because of its shape, can lead to increased turbulence, which can lead to valve problems as the person gets older. These valves are defective, so they can develop aortic stenosis or aortic regurgitation, and bicuspid aortic valves are also prone for endocarditis. Hence, it is important to consider endocarditis prophylaxis in patients with a documented evidence of bicuspid aortic valves. The diagnosis is by 2D echocardiography and or MRI. When these patients present with a significant aortic regurgitation or infective endocarditis, they may need aortic valve replacement. Next, let's talk about ventricular septal defects. Ventricular septal defects are also an important congenital abnormality that we encounter in the adult population. In majority of the cases, the ventricular septal defects are generally asymptomatic. If you look at the picture here, the ventricular defect can occur anywhere along the interventricular septum that separates the right ventricle and the left ventricle. It could be in the upper part near the attachment of the aortic root and the mitral and tricuspid rings, and this is called the membranous type of ventricular septal defect. Then we have the muscular type of ventricular septal defects, which are sort of a fenestrated holes in the ventricular septum. The ventricular septal defects may also be associated with the Down's syndrome. The membranous type of ventricular septal defects account for 80% of the ventricular septal defects that we encounter in the adult population. Majority of the muscular ventricular septal defects, they close as the person gets older, and also the murmur in the muscular type of ventricular septal defect becomes softer as the ventricles squeeze and the small defects close. The muscular ventricular defects account for 20% of the ventricular septal defects that we encounter in the adult population. And of course, there is a left to right shunt. In the modern days, there are closure devices available to close large defects that have a QP/QS ratio of 1:1.5 or greater. Another rare type of ventricular septal defect is the supracrystal ventricular septal defect or infundibulous ventricular septal defect, and that is seen in 6% of the patients, whereas it is 30% of the patients with ventricular septal defect from the Asian origin have this type of ventricular septal defect. Let's move on to the next problem, and that is the patent ductus arteriosus. Again, this is one of the remnants of the fetal circulation. During fetal circulation, the blood that is channeled through the right atrium into the right ventricle through the pulmonary artery goes through the patent ductus into the descending aorta and then return to the maternal circulation, since majority of the blood is not going to the collapsed lungs in the fetus. However, between 24 hours to 30 days, this ductus arteriosus closes because of the bradykinin that is produced in the lungs that causes vasoconstriction, along with reduction in the prostaglandin level with better oxygenation of the blood leads to closure of the ductus arteriosus. However, in infants, if the ductus arteriosus persists and if it remains open, it can be treated with indomethacin or ibuprofen, which promotes ductus closure. If the ductus appears to be large, nowadays we can close it percutaneously by going through the right heart system. Coarctation of the aorta is another congenital abnormality we encounter in the adult population, where there is narrowing of the descending thoracic aorta, generally just beyond the point of ductus connection. This narrowing can be like a napkin ring type of constriction in the aorta, which causes differential blood pressure between the right arm and the left arm. These patients can present with hypertension, leg fatigue, and differential blood pressures, which as we talked about. Again, coarctation is associated with Turner's syndrome, and patients with coarctation may also have bicuspid aortic valves. CT angiography is the best way to confirm the diagnosis of a coarctation of the aorta, and it generally requires a surgical repair. It can also be treated with a balloon angioplasty. Here are some examples of how coarctation is corrected surgically by resecting part of the descending thoracic aorta and making an end-to-end connection, or just opening up the artery and adding a patch to increase the aortic lumen size. Here's an example of how a balloon is used to open up this napkin ring type of constriction in the descending thoracic aorta. All right, now let's talk about tetralogy of Fallot, or STET as it is called. This is a very common congenital heart problem that we encounter in children, but it is not uncommon to see some of these children who have been surgically treated, who can reach their teenagers and adult years, and these patients may show up in your private practice or clinical practice, and hence it is important to know something about tetralogy of Fallot. I have seen a handful of patients with tetralogy of Fallot who, after they turn 18, are told by their pediatricians to see adult cardiologists. Anyway, tetralogy, tetra means 4. Tetralogy of Fallot means 4 abnormalities all encountered in one heart. First, we have pulmonic stenosis. Then there is ventricular septal defect. We have the overriding aorta and also atrial septal defect. All these 4 abnormalities combined together is called tetralogy of Fallot. Babies born with tetralogy fail to thrive. They may have TET spells where they may exhibit severe cyanosis. These children will also be short of breath. They have weakness, and they also manifest with polycythemia. In some cases, it may be necessary to operate on these infants in order to maintain adequate oxygenated blood through the circulatory system. As I said, generally there is shunting of the blood from the left side to the right side at the atrial level and also at the ventricular level in patients with tetralogy of Fallot. Now let's talk about detransposition of great arteries. As the name indicates, the aorta is attached to the outflow tract of the right ventricle, and the pulmonary trunk is attached to the outflow tract of the left ventricle. Now we have two closed circuits which do not connect with each other. In other words, the venous blood coming from the rest of the body goes through the right atrium into the right ventricle, into the aorta, then it goes straight into the rest of the body and returns to the superior and inferior vena cava. On the left side, we have the pulmonary veins which bring the blood to the left atrium, then it goes through the left ventricle into the pulmonary artery, which goes into the lungs, and then it returns back to the pulmonary veins. So we have two independent circuits. The only way a child can survive is through having a connection at the atrial level or the ventricular level, so that the oxygenated blood mixes with the venous blood in the right side and is eventually pumped into the arterial circulation. This defect needs to be corrected within the first year of a child's life, otherwise they are going to have a pretty poor prognosis. Again, we also see hypertrophy of the right ventricle in order to maintain systemic pressures. This is one of the congenital heart diseases that is noticeable right after the baby is born. Pulmonic stenosis. Pulmonic stenosis is another congenital heart disease that we come across where there is narrowing of the pulmonic valve. Just like congenital aortic stenosis, where there is narrowing of the aortic valve, the pulmonic stenosis behaves just like aortic stenosis in that there is hypertrophy of the right ventricle. There is evidence of increased pressures in the right ventricle and the right atrium. There is increased thickness of the right ventricle. Pulmonic stenosis should rhyme with Noonan's syndrome because there is patients with Noonan's syndrome have pulmonic stenosis in majority of the cases. In most cases, this can be treated with a balloon valvuloplasty so that we can increase the orifice for the flow of blood from the right ventricle into the pulmonary arteries. Tricuspid atresia. Tricuspid atresia means basically non-development of the tricuspid valve. It acts like severe tricuspid stenosis because there's hardly any blood going through the tricuspid valve. As a result, there is enlargement of the right atrium along with rudimentary right ventricle. So somehow the blood has to get into the pulmonary circulation. The only way the blood can get into the pulmonary circulation is to have the right-sided blood shunted through the atrial septal defect and then through the ventricular septal defect, oxygenated and deoxygenated, or should I say mixed blood goes through the pulmonary circuit. And since the blood is mixed from both the right and the left side, both the pulmonary artery and the aorta receive mixed oxygenated blood. Total anomalous pulmonary venous return. There are 4 pulmonary veins, and all the pulmonary veins drain the oxygenated blood from the lungs into the right atrium. These pulmonary veins are attached to the left atrium, and in patients with a total anomalous pulmonary venous drainage, the pulmonary veins are attached to the right atrium, or more often they are attached to the superior vena cava. As a result, all the oxygenated blood is coming back to the right side. As you can see, the venous return from the right atrium pumped through the right ventricle into the pulmonary artery goes into the lungs, and then it returns back to the right side of the heart. So there is somehow the blood has to get through to the left side to be pumped into the aorta to maintain the circulation through the rest of the body. And this is generally accomplished through an atrial septal defect, which will pump some of the blood into the left atrium, then into the left ventricle, and eventually into the aorta and the rest of the body. This is something you're not going to get it on the boards, but it's nice to learn while we are talking about congenital heart diseases. Eisenmenger syndrome. You may get one question on this one. What is an Eisenmenger syndrome? Eisenmenger syndrome is a clinical manifestation of a far advanced left to right shunt, which becomes right to left shunt as the pulmonary vascular bed becomes more and more restrictive. Initially, in patients with atrial septal defect or ventricular septal defect, they have left to right shunt. But with increased flow over decades, the pulmonary artery becomes sclerosed, so the lumen becomes narrower and the vessels become stiff and fixed. So the pulmonary vascular resistance goes up considerably higher and in many cases above that of the systemic vascular resistance. As a result, now the blood, instead of being shunted from the left side of the heart to the right side, is now shunted from the right side to the left side. As a result, the patient becomes cyanotic. So what are the main features of Eisenmenger syndrome? The systemic to pulmonary circulation connection, that is atrial septal defect or a ventricular septal defect. Initially, we have the blood going from the left side to the right side of the heart. That increases pulmonary blood flow. It causes irreversible pulmonary vascular injury. This leads to increased pulmonary vascular resistance. And finally, we have right to left shunt, which leads to hypoxia and polycythemia. That is Eisenmenger syndrome. By the time a patient reaches Eisenmenger syndrome, it is too late because the fixed pulmonary vascular bed cannot change even if we were to correct any underlying congenital abnormality in the heart. So the best time to do this is when the pulmonary vascular resistance is in a reasonable range. Here is an example of Eisenmenger's pulmonary artery showing extensive amount of duplication of the tunica media, which leads to narrowing of the lumen of the pulmonary vascular bed, leading to significant pulmonary hypertension. Well, ladies and gentlemen, this is an overview of congenital heart diseases that we may encounter in the adult population, but it is certainly important to pass your boards. I hope this has given you some tips on how to study for your cardiology section of the board. And thank you so much for watching. I am Dr. Nik Nikam, and please do subscribe to our YouTube channel and tell your friends, and we will see you next time. Thank you so much for your attention.